most important things I teach therapists about trismus intervention. If you're a therapist working with head and neck cancer patients, one of the most common questions I hear is, when should I intervene for trismus? I'm Lauren Meffin, a speech pathologist and certified lymphedema therapist. And today, I'd like to share with you some of the key principles I teach clinicians about trismus intervention. The first thing, we need to understand that radiation-associated trismus is often a lifelong side effect of cancer treatment. Many clinicians assume that once the treatment ends, the problem is over. Unfortunately, that is not what we see clinically. Radiation creates a progressive change within the muscles of mastication, connective tissue, and surrounding structures. Over time, these tissues can become fibrotic, they can become dense, restricted, and as a result, the mouth opening will gradually worsen for years after treatment. Because of this, our role as therapists begins much earlier than people realize. I teach therapists to think about trismus management in 3 phases. Phase 1, we establish a baseline. We want to measure the opening of the mouth even before treatment begins, whenever possible. We also want to educate the patient regarding the potential side effects and discuss the realistic expectations. Trismus is generally defined as a mouth opening less than 35 millimeters, but even patients with a larger mouth opening can be at risk depending on their tumor location, surgery site, and radiation fields. In this stage, education is critical. Now let's move into phase 2, during radiation chemotherapy. Patients will experience pain, fatigue, mucositis, and ultimately we as the therapist are often asking ourselves, should I intervene aggressively during treatment? The answer always depends on, why is the mouth opening restricted? Typically, it is because of a tumor itself or the surgery, or is the mouth opening reduced due to pain or inflammation? Understanding the cause of that restriction will help us to guide our intervention and our timeline. The goal is to maintain during treatment, not improve. For our mouth opening, instead, we are working to preserve their function, monitor their changes, and provide education, all the way until phase 3. This is where active intervention becomes incredibly important for our patients. The patient has completed treatment, inflammation is beginning to settle, and now we are going to focus on restoring, maximizing their function. One of the biggest mistakes I see is applying the exact same protocol to every patient. Why? Every cancer is different, every surgery is different, every radiation field is different, and every patient responds to pain differently. This is why I believe that we should individualize treatment, and the therapist must begin to recognize that. Our role is simply not to hand our patients an exercise sheet, it's to become a clinical decision maker, understanding where is the tissue healing, where is the fibrosis, the pain coming from. Our goal is to add functional outcomes and teach our patients their trismus timeline. Patients believe if I begin to do this stretch, then I can stop it. That's not true. Without intervention, many patients will show a slow decline in their mouth opening over time. I describe this as a red line trajectory. As fibrosis progresses, mouth opening declines. Early identification, ongoing monitoring, and patient education puts us onto a green timeline. We want to improve our patient's mouth opening over time rather than wait until the restriction develops. That's why I advocate for baseline measurements, measurements at diagnosis, follow-ups during treatment, post-operative measurements when appropriate, and continued monitoring during survivorship. Education matters, measurements matter, and early intervention matters. This is a lifelong process to maintain mobility, preserve quality of life. And as therapists, we have an incredible opportunity to change the trajectory for these patients. If you'd like to learn more about the Trismus intervention framework, including assessments, tools, progression, manual therapy techniques, download our HNC Lymph SLP app using the link below in the descriptions. We also have created handouts, videos, and clinical resources that are designed specifically for therapists treating head and neck cancer survivors. I thank you for joining me as we continue this work together to improve the outcomes for our patients with head and neck cancer.